psychological co-morbidities are a very important part of cluster headaches. But
Painting for me how the pain feels like a knife stabbing into his left eye. I'll never forget that image.
I've asked a friend to punch me in the face.
Pain can be so isolating. And I know it is hard to reach out when you're already down, you don't have energy, and you feel like you're...
Hello and welcome everybody. Welcome back everybody. This is MyClusters Beyond the Pain. I am Darshan, a cluster headache patient and founder of MyClusters, a cluster headache tracking and analysis app and a research platform. Very excited with our guest today. Today we have Dr. Lea Jabbarian. Dr. Jabbarian is a healthcare psychologist and epidemiologist. She is affiliated with the MISI Neurosci and the Erasmus Medical Center, Rotterdam, where she combines clinical care with education and scientific research. Her research focuses on mental health, shared decision-making, communication, and diversity and inclusivity throughout various healthcare settings. She is part of the advisory council of the Dutch Association of Psychologists and has been part of various consortia and clinical guideline groups. And she's a scientific advisor to MyClusters. Last year, she helped us with a study on psychological comorbidity and presented our first poster ever at the European Headache Congress in Lisbon. Welcome, Dr. Jabbarian. Anything that I missed out?
I think that covers it. Thank you so much. Very happy to be here today.
Yeah, and we are really excited to have you as well because we, of course, covered the clinical aspects of the disease, and you are a psychologist, and I think most patients will know. And if someone doesn't know too much about cluster headaches, they will be surprised, or maybe shocked is too strong. Let's say they'll be surprised to hear that psychological comorbidities are a very important part of cluster headaches, but also chronic disease. I know I myself have gone through it. We've spoken about it before, of course, like when I was doing CBT for depression, or last year with anxiety, with the meds and everything else that goes on. I think the clinical word is interictal burden, but that is something that we came across in the study as well. So really looking forward to chatting more about those in details. Let's start with how your first experience was in dealing with cluster headaches, because I know you've told me you've dealt with patients.
So some years ago, I used to work in the Erasmus Medical Center in Rotterdam, and I used to work as a psychologist in the pain department, where I saw all kinds of patients with different pain symptoms, among which patients with cluster headaches. And I remember it was a disease. Well, it is rare, as we all know, and I didn't know too much about it. And then I saw these patients, and I was so impressed with their resilience and the way they kept showing up for themselves in managing their disease and still creating a life that's worth living for them. And that was the first encounter with this patient group.
So you knew nothing about cluster headaches then?
Not too much, really, no.
What was your impression like when someone came and said, I have this unbearable pain, presumably, and did you think it was migraine? Did you think maybe it was another undiagnosed condition? What was your sort of immediate reaction?
I think what I thought is like how unique the pain experience is, because before I used to work in oncology and most specifically in palliative care. So I knew a lot about pain that can come across any kind of cancer and in the last period of life. I also worked a lot with elderly. So I was known to phenomenon of pain. But having these attacks of the most unbearable pain you could possibly imagine, it was new to me and quite shocking, really, that something like that exists.
And sometimes, especially in kids, I know of a few stories where maybe pain is also one of those things that are universally co-adopted, right? Like headaches. So when it's headaches, the problem is that you get advice from everywhere. Drink some water, take paracetamol, etc. I think pain is also one of those things. And I know of a couple of stories. One specifically with the kid that was undiagnosed. And when he went multiple times describing his pain, they thought he was making it up.
Yeah.
Or, sometimes you also hear advice and theories about pain and how to deal with it. So that gets me really interested in pain. So just to sort of quash the rumors or the misconception or the misinformation from your experience or what you know of, how real is the pain?
I think I'm not a judge of anyone's pain. And if it comes to physiological or psychological pain, like I'm not the one to judge if you have the right to have that pain. I take my patients, anyone really serious with the experience they have. And if they describe to me, this is the worst pain possible. And I remember a patient even painting for me how the pain feels like a knife stabbing into his left eye. I'll never forget that image. I believe you, and this is the pain you describe. So this is the pain you have, and this is very real in your experience.
Understood. And is there, now talking in general about pain, of course, is there any psychosomatic, I don't know if I'm using the term correctly, is there in general anything from that is attributable to pain? Is it in our head?
I remember the professor I used to work with there. He wrote his professor dissertation, however you want to call it, with the title, yes, pain is in between your ears, it's in your head, but not the way you are imagining. So not in the way of that you just imagine this pain and it's not really there. The pain is there. But definitely it has something to do with how your brain processes information. And what I found very interesting when I got into the whole area of pain is to find out that actually the theory of how pain is being processed was developed by a medical doctor and a psychologist.
Mm-hmm.
Because, of course, the medical doctors are all about nerves, synapses, spine, how information processes in our or is transmitted in our body. And the psychologist comes in when it comes to how that information is processed in our brain and how our brain makes sense of the different pains. Because as everyone knows, it feels very different to burn your finger or to hit your little toe against the chair that's laying around. So there are different tastes, if you can say so, of pain. And that's where psychology comes in, how the brain translates those signals.
That's super interesting because one of the things I do myself, let's say when I don't have oxygen, where I don't have any abortives, I remember distinctly, this was usually on holidays when I was in between cycles. So I wouldn't carry this. This was 4 years back, maybe, when I wasn't as educated, let's say. And then this was quite common that I would just bang my head and just, just kick something and feel pain somewhere else. Just so, it's acidic pain is so bad that you welcome pain in another area. So it's a momentary distraction. So I can definitely relate to the part of the how you're processing it. Then you're in so much pain, you're processing how painful that is. And then there is a background sort of processing that happens, sort of like, why am I going through this pain? Why does this not end? When will this end? How does one deal with that?
Yeah. Oof, that's the big question, right? And before I want to answer this or like explore some ideas on that, let me quickly zoom in back on what you were saying to kind of create a distraction pain, which already shows how interesting this is, that because our brain processes stimuli differently, one pain can, for a short time at least, overshadow another pain. So that's a physiological mechanism that you were using to maybe overshadow a bit of the cluster headache pain. But then there's also a psychological variable to it, that it is more pleasant to give pain to yourself by hitting something than experience the pain that the cluster headache is causing. So that variable also comes into play.
Which, again, no one should do. And I was an idiot for doing it. But again, I don't know. I can't say with certainty that I won't do it again. So that's That's how this is me rationally now telling you that, it's not a good idea. And to any listeners out there, no, it's absolutely a horrible idea. Do not try this at home. I've asked a friend to punch me in the face, and the I don't know if that's a very good friend or a bad friend, but he took it. He took the chance.
Yeah, I'm appreciating that you are sharing this, because this is like in your darkest moments that you turn towards hurting yourself to distract from this horrible pain. And I'm sure many patients can recognize that experience and either have done it themselves or had thoughts of it. And I think it's important that we do talk about it.
Yeah.
And then to reach out to healthcare professionals to show you, and coming back to the question before, how can you manage the pain differently? Where, again, we don't want to advocate for anyone inflicting pain on themselves. But of course, I can completely empathize with the idea that you would do something because you are so desperate that you would literally do anything for just a little bit of time.
Yeah, for a second, for a fraction of a second.
Yeah, for sure.
Yeah, and then absolutely on the professional help, and I'm going to get to the results of the study we did last year and why it's crucial to have not just neurological support, but psychological support as well. But I think the other part of what you said about being able to talk about it, being open about it, I think first it's almost like, I think of it as like the 5 stages of grief, right? So you're kind of in denial, bargaining. And if I break down my disease journey so far, I think now in the last 2 years, it's only like the last 20-25%, but a lot of the first 75% of the time was denial. So when I was in denial, or bargaining, then I wouldn't talk about it. I think the other thing that made a big difference is talking to other cluster heads. And then you realize, 1, you are not alone. 2, you end up exchanging stories and you realize how similar they are. And that's really what's made the difference. I think about 2 years back is when maybe not even 2 years exactly, like a year and a half back is when I went to conferences or through MyClusters, started talking to a lot of our regular users. And then I realized, okay, it's uncomfortable, but I think talking about it will help. At least if someone's there is listening and they're going through something, they know that this is not a good idea to hurt yourself.
No.
1. And 2nd, you're not going through this alone. So
it's even harder with cluster headaches because, again, me as a healthcare professional, I didn't know about it at first, leave alone someone who is a patient or a potential patient of it. So when it happens first, you don't know what's actually happening to you, and you don't read about it a ton. And especially because they come in clusters, you went through one and you're like, okay, that happened once. And then it happens again and you're still trying to figure out. So it's very hard to open up to people if you yourself don't understand what's actually happening to you. And it's very scary. But I think it's very important that we encourage people to reach out to friends, family, healthcare professionals, teachers, whoever you want to trust, to share some ideas, because it can be very isolating.
I think, and if you don't know where to start with, there are communities, of course. I can leave the links in the description. You're online, whether it's Facebook, Instagram, Reddit, there's a lot of wonderful communities out there. Going back to the question though, these underlying thoughts about the demons that come in and say like, okay, why is this happening to me? Why does this hurt so much? When will this end? What's your understanding? And maybe if it's too specific during cluster headaches, like how can our listeners understand what happens to us when we're going through anxiety?
Yeah, I think what I want to say is almost as a disclaimer. First, of course, I wish I could take away cluster headaches with psychological interventions, but that's not the case. So I'm not going to pretend that this will take away the pain. However, what I did see with patients is we work on exactly these inner demons, as you call them, that the pain experience can still be less severe. And that is also very welcome in someone's life, or that at least you open your horizon to more than just the pain. Because again, it can be very isolating. So that definitely is something the patients benefit from. And I remember one patient who, through the conversations, we came to know that she always had the idea, because of various factors in her life, that she was just not supposed to be happy, that she was in a way cursed, if you want to call it like that, and was just not supposed to be happy. And once we worked on these ideas, she could actually open up to more opportunities in her life, and the pain experience went down a lot. So yes, she was still having pain, but it was much more manageable. It was much more doable in those moments, and she could include more positive things in her life next to the pain. And this is one very quick example of how we can work on still working on these thoughts and improving
And
experience.
what did you notice that changed then, before and after?
Before, she was, and I remember we had this discussion as well, that you don't call people cluster headache patients, but patients with cluster headache or people with cluster headache. But before I saw her, or like when we started, she was a patient. Her whole identity was being a pain patient. That was all she was. That was all her life was about. When we started working and when we were done, she was herself. And she was a friend and a daughter and a professional. And yes, she also had pain, but we broadened her identity to make it more than just about the pain.
How do you deal with the anxiety? I mean, I can speak for myself. I think a major part of the anxiety when I'm in a cluster period is finishing one attack, and you feel good, really good for like a minute or two. And then suddenly the thought kicks in, like I'm going to have one very soon. And I've had multiple cycles where it would be one a day, then it's not so bad. But I've also had 6 a day, and those days were brutal. Like it's almost like if I could have one attack that was the combined duration of the 6 attacks and just be done with it, it would be better than, just get done, start feeling better only for an hour later, and then you get up from that. You have night attacks, right? You go to sleep and you're dreading going to sleep. For 3 months, I didn't sleep in my bed because I was associating that with attacks. So then that kind of anxiety. I've spoken with chronic patients that say predictable attacks are better for anxiety. Like, of course, it's the best to not have attacks, but that's not the reality we live in. But if we know that, and for the listeners out there, cluster headaches are somewhat predictable in the sense of they have temporal patterns. So with some chronic patients that I've spoken to, then they say it's better if I have it at 10 a.m. every day, and then rather than 10 a.m. one day, 11 a.m. one day. But what is true is that you can go into an episode without any specific trigger. And when you think you are out of it, like you plan a travel, for example, which has happened to me last summer, and then it kicks in and then you cancel your travel plans. So things that you think are normal, right? Planning around the holidays. So that's a rather long question, and I don't know if that's a well articulated question, but I'm interested in like understanding from your point of view the like anxiety in general, right? Even for the listeners.
I think what this shows is how complex it is, and what we need to do in psychology. We always say one size fits nobody. So for every person and every circumstance, we have to design interventions. So we, as let's say, as a therapist and as a patient, we work on strategies during the cluster headache period, let's say, and strategies in between, so that you always have something to use wherever you are in life. Also, if something unexpected happens. As he also said, the anxiety shifts between, oh no, in 1 hour it will probably happen again, to, okay, now I've been cluster headache free for a month, but I know flying is coming and probably that will trigger, etc. So the anxiety is different. So what we want to do is to be more specific in identifying which are the anxious thoughts depending on which period, so that we can use techniques that are relevant and specific to that particular anxiety.
How does one do that? I mean, let's assume that there's a listener and who doesn't have an access to a psychologist, right? And okay, let's not abstractify it, but let's say it's me. I don't have I'm listening to this podcast. I don't have access to any kind of therapy. What can I do to one, identify if I'm having and showing any signs of anxiety, and I'll plug in depression also here, because I think they might go hand in glove. And yeah, what are the signs?
Yeah. I think you're saying the right thing. First step is to observe and actually realize, like, hey, this is an anxious thought. Because be aware that maybe this is getting too philosophical, but reality doesn't really exist. Everything we perceive is an interpretation. I don't want to go too deep into that, but like, let's assume that. So if you have a thought, be aware that thoughts are not reality. It is an interpretation of what we see. So what we always, one of the biggest goals in therapy, what we want to achieve is that we are able to zoom out from a situation and look at ourselves from a distance. And then being able to identify, hey, is this a depressive thought? Is this an anxious thought? Is this a happy? What is actually going on? And I think what would help people as a first step is to be more aware of what they're thinking and what they're feeling. And what helps, because also a lot of times we think a lot, we don't actually pay attention to what we're feeling, is to ask yourself, wait a second. So, right, doesn't matter. Listeners, wherever you are, take a second and zoom in, connect with yourself and ask yourself, are you happy? Are you scared? Are you sad? Or are you angry? That's enough. Just these basic 4 emotions. Check in with yourself. What are you feeling? What are you feeling in your body? What are the signals in your body? Because your body tells you which emotion you're feeling. And then connect it to a thought. That's the first step.
I have tried this, and I'm sorry if this puts you on the spot. Like we've spoken about this before. I have tried CBT, cognitive behavioral therapy, and it did nothing for me, because all I was doing is, yes, I feel pain. I am in pain. How does it make me, like, I feel angry because of the pain. I feel frustrated about the pain, and this was 3 times a day, 4 times a day, right? And I don't know if I didn't do it properly or whatever, but I couldn't think beyond that. Is that helpful in this case? Or if what you're saying is maybe a less barrier to entry, like just a starting step?
Yeah. Well, the thing with CBT is the idea of CBT is that we have some distorted thought. And by using the techniques, you nuance the thought. But if you have a thought of, I feel pain, or you realize you're scared and the thought is like, because maybe a cluster headache attack will come, or a panic attack for that matter, that's not an unrealistic thought. So then CBT is actually not the right strategy to attack, to work with that thought, because the threat is real. However, how you react to it, that's something else. So how you were saying that you were avoiding your bedroom because you associated it with an attack, that's something, for example, you could work on, because the bed in itself is not going to trigger an attack. Your brain just made the connection. I had an attack here, so this is dangerous, so I'm going to avoid it. But there's somewhere. Sorry?
It's bad luck.
Yeah, but that is one interpretation we do. So again, we want to zoom in a little more, like what exactly is going on. But to come back to like what can people do is to first realize what's actually happening. What am I thinking? What am I feeling? And then based on those thoughts, we look a bit more into it. Like, okay, what's behind this thought? Do we need CBT techniques? Maybe. But maybe we also need other techniques. There's another therapy that we use a lot for pain. It's called acceptance and commitment therapy. So where you are much more about, okay, we know there's the threat of a cluster headache attack, for example. And how else are you going to shape your life? What else are you going to do? What's important for you in your life? What are the different roles you have in life? How can you, in this half hour that you have between attacks, still make something that's worth it for you, to make it really, really, really small? But
and I'm just trying to be an outside spectator here. As you were talking about it, I just kind of imagined a consult happening. Is it not difficult then that I imagine you get a lot of pushback also saying that I can't do all this, I'm in pain. You don't understand what I'm saying. Like, how does this help me when I'm struggling with a chronic disease? Like, these like happy thoughts going to help me. And I suppose there are common stereotypes associated with psychology and therapy as well here. But I mean, we have people everywhere, right? And there's like cultural and socioeconomic things that come in as well. How do you deal with those difficult conversations?
I think what you said, like, you don't understand how it is to be me, for example. Of course not. I will never know how it is to have a cluster headache attack. I also was never depressed, or I was never traumatized in the PTSS sense. Like, I don't know. And luckily, as psychologists, we don't have to go through all the misery of the world ourselves to understand and empathize with our patients. But what is the first step before any kind of technique and theory is to understand the world you're living in.
Mhm.
Help me to understand how it is to be you. And I'm not trying to convince you that the pain is not there or just think a happy thought and it will go away. No. First, I have to understand how your world looks like. And then we start working together. But what also happens, like this resistance that you're describing, is very common in patients with pain, but really patients with any kind of complaint, because misery, even if it is misery, the known is always more comfortable than the unknown and the new aspects. And this is also what you were just describing. It's almost nicer to know that the pain will come at 10 a.m.
Mhm.
and maybe knowing, okay, it will not be there for a month, because what we know is always more comfortable for us as human beings. It's just like that. We love routine. We love the
Yeah,
predictable
we're
things.
creatures of habit.
Exactly. So when I come in and I say, okay, we've tried this, feeling angry, feeling scared, being stuck in those thoughts, we know this, maybe we can try out something else. We don't want to get rid of this because we can always go back to being scared and sad and angry, but maybe we can also try this. People are not going to say, yeah, great, let's do it. They're going to fight with me a little because they're like, who are you? You know nothing. You don't know how the pain is. You don't know how it is to, no, I don't know. That's also not the objective of the therapy. So first we work on establishing that maybe next to these strategies you're already doing and being immersed in the whole pain experience, we can also try out something else.
It's fair. And talking about misery, talking about depression, how do you and maybe I'm still confused. Like, what's anxiety? What's depression?
Why does it matter to you to make a difference there?
Just knowing, right? Like knowing what is going on. And I suppose in a way, knowing will help towards doing something about it.
Yeah.
I mean, I didn't know when I got that first diagnosis for depression that I there was something that said just reach out, get therapy, because I knew I wasn't what I was going through wasn't normal, and I just wanted to talk to someone about it. And I thought it should be a professional. But the first thing they asked me was to finish a questionnaire, and then I mean, it seems in hindsight, it seems clear that I can remember questions like, how often do you get out of the house? And that time I would get out like once in 3-4 days. And what activities do you find joy in? And then the only thing I was doing is keeping up appearances with my friend circle, because then otherwise then that would be like a clear sign. But I wasn't taking any initiatives. I wasn't making any plans myself. And I was spoke to my family about what I was going through. And then now it feels like, yeah, that could be, those could be signs. But at that time I didn't know. So knowing what it was helped. Okay, CBT didn't help, but at least it helped me take that step towards, like not drinking alcohol. Or, I mean, that was also mostly because of the attacks. But at some point I realized, like you said, that there is whatever time I have in between attacks, if I could go out for like 2 minutes a day or make myself healthy to deal with life better. So it was partially resignation that, okay, this is now I'm not in denial anymore. This is going to be a part of my life. So I better do something to make my life in between attacks productive or social or whatever, right? And at the time I wasn't working also. This was already like 5-6 months after I quit my job. So knowing that, I think kind of put a spark in me that, okay, this is something I have, which is depression. So I need to maybe do a little bit of exercise. And it wasn't easy. And it's not like I suddenly started exercising the next day. This was now I'm
Yeah.
comparing what happened over a period of a month or a couple of months into like one story. But that's why it was important for me. I was saying mostly for recognizing
Yeah.
signs. Also, like if there's anyone that is listening and can relate to something that they hear now, then I'm hoping it can have a positive effect.
For sure. And I think why I'm careful though is because I don't like to throw around clinical terms, because there's also a different, right? How difference in like everyday life, how we say something is traumatic. And there's a difference between trauma and PTSD. And there's a difference between I'm anxious or depressed and clinical major depressive disorder. So why I'm also saying it is because I wouldn't want people to find all kinds of online resources where they tell you about this symptoms of depression to then justify, oh, I'm not feeling good, I have depression, only then I'm allowed to find a healthcare professional. I think I would want people to encourage, if you're not happy, find a healthcare professional and let's talk about it and let's see what it is. And then to put the diagnosis, the right, label, that's for the healthcare professional to find out what to focus on. But I think I'm saying it to make people take themselves seriously and reach out without having to feel like, oh, I need to have this and this at 5 out of the 10 to justify reaching out to a healthcare professional. No, you have every right always to reach out to us. And then let's find together what it is.
No, I didn't want to put you on the spot with the clinical definition, and good on you for taking a stance on unlike 99% of the internet.
Yes.
But it was more of, maybe if I flip the question, let me rephrase the question. How do you know if when you're treating someone with a chronic disease that they are dealing with it okay, or their psychological or mental health outside of their actual disease, that mental aspect of it, the psychological aspect is like signs of, I don't want to say healthy, but I can't find another word for it. But
yeah. No, I think also why it is good to recognize these symptoms in yourself is because when you're dealing with something that is so rare and so debilitating, is you get so used to being unhappy that you almost don't realize anymore that this doesn't have to be like that. And in that way, it helps to know, oh, it's for 2 weeks you don't sleep, or you sleep much more, or you don't eat, or you overeat, or you don't engage in these activities, or you have thoughts of blaming yourself or feeling guilty, and you feel sad, crying, and all these things, guilty. Those are symptoms of depression. So it does help, I guess, to realize that this is not normal. It's not, you're not supposed to feel like that every day. We can all have a bad day every now and then. But if for 2 weeks you have this most of the day, then go find someone to talk to, a professional, next to your personal private network, and talk about it to see if it is depression or anxiety.
to someone that knows nothing about healthcare systems, like let's say in the Netherlands or Germany, for example, how does one practically go about doing this?
I think the first step is usually the GP. In the Netherlands, the GP coordinates all care. And in general, I feel like the GP is the first one to reach out because they are aware of health care facilities and whatever the healthcare system can offer to you. So if anyone is doubting what to do, I feel like the GP is always a good step to reach out to. And they can refer you for both the medical side of health as well as the psychological side of health.
I suppose, different people will have different experiences with GPs, but that's another topic. But I'm actually thinking about the study we did, right? So in the study, of course, it was with the third year medical students of the Erasmus MC in Rotterdam, and the students did a great job, and they conducted interviews with cluster headache patients with cluster heads and cluster headaches, cluster heads. And one of the things that came up also is these patterns, right, of how it is to deal with the disease, but also additionally about the social isolation that you have when you have the disease, the lack of awareness. So one, of course, you have to let's say with normies or lay people, that give you advice, but also at the primary care level. And we do at most times have to, we are in an environment where, except possibly like the neurologists that are treating us, and then I'm speaking for myself here, that they are knowledgeable, but almost everyone else that I come across is not. So how do how do I deal with a GP when I'm talking about my like anxiety or depression, and I say it's because of cluster headaches, and then my GP says, "Oh, for cluster headaches, like do this, or like whatever, like take paracetamol, or like how
Yeah.
can we navigate through this smarter?"
Yeah. And unfortunately, I recognize that a lot from my patients that I saw that they told me, like, for so many years, they've been trying to get help, but people were telling them, oh, you're just stressed. You just started a new job. Your relationship just ended or started or is in the middle. Or like people were always attaching their symptoms to circumstances. And that's why I'm I want to repeat myself in like, take yourself serious. If you feel unhappy, scared, angry, whatever, take yourself serious. Even if you're not sure it is depression or anxiety, go to a healthcare professional. And if they say, yeah, take paracetamol, wait 2 weeks, or do X, Y, that,
Yeah.
be insistent. You don't have to fight, but be like, thanks for that tip, and I tried that out, or I will give it a chance. And also, I would like to have a referral to a psychologist or to a neurologist to just make sure that nothing else is going on. And it's always fair to try that out as well. So don't give up. And I unfortunately, I have to tell patients, don't give up and do ask for that referral. On the healthcare side, we are also doing our work and advocating for pain and in this specific context, and telling our colleagues about how to recognize those systems. So we're also working on that. So patients don't have the responsibility of finding their right pathway. But in the meantime, be insistent on what you feel like until you are at the right place of care.
In the healthcare system, like, I completely agree with what you said. I think anyone with cluster headache should automatically get in without having to fill intake forms, and I mean, not discounting other diseases, but I think everyone with cluster headache should get help from therapy. But it's, practically speaking, it's different departments, and it could be that your a neurologist knows something, but your psychologist doesn't. And
Yeah.
one of the things that came up in the study as well was the talk of integrated care, or how we could benefit from this sort of holistic approach, not holistic in terms of medicine, but like approach from all angles, right? So a neurologist to treat the pain and the other symptoms, psychologist for therapy, perhaps someone from the pain poly, from the for the other nerve blocks and everything. What are your views on that?
Oh, completely. Like if you would give me a couple of billions, I would do that everywhere. And I'm very proud that in Erasmus MC and the pain department, we had that. So we had pain specialists who are usually anesthesiologists with extra training. We also had neurosurgeons, we had neurologists, we had psychologists, and we had physiotherapy, which we also don't want to disregard, and nurses, which we also don't want to disregard because they're also very important in the management of patients. And in our outpatient clinic, we would also see patients. The medical doctor would see the patients, the physio, and then me, or the nurse instead of the physio. And I think ideally it should be like that everywhere, that you need specialized people, because as you said, it's too specific pain in general, and particularly cluster pain, cluster headache, to leave it with the general psychologist even. You need special training, special knowledge, and especially the collaboration with other healthcare professionals to deal with this effectively. So if possible, I would implement these multidisciplinary teams everywhere.
But that's ideal. So is there no in between? Like, is there no in between where you say, okay, you've been diagnosed. It doesn't have to be within, but like it's a recommendation that you do get 3 sessions of therapy, or you do get like at least one consult.
Yeah, I luckily in the Netherlands, and I say luckily because it is actually rare worldwide, psychological care is covered by insurance. So you will never have to pay for it out of pocket. So I would encourage any patient that doesn't have access to an outpatient clinic where you have a multidisciplinary team to put your own multidisciplinary team together. So to find your neurologist, pain specialist, to find physio, because we don't want to disregard also the impact of movement and the body, and to find your psychologist. And I think also you don't always need a super specialized psychologist, but you need to find a psychologist who is willing to put in the work to educate themselves. That's not on you as a patient. This is on us as professionals to educate ourselves. And if we have a patient with something that we haven't seen before, we should do our research and we should educate ourselves to help you.
And but the reality sometimes is that first step, the onus is on us, right? We have to advocate right now for like specific. I'm talking specifically about therapy, but I think in general, also about in many parts of the world, also about cluster headaches itself. And again, going back to the pain, again, going back to the fact that it's highly likely that you are depressed, you have anxiety, we saw increased suicidal thoughts as well. How do I now get up, finish my attack, and then go, like, okay, I need to go to the GP, convince the GP it's not related to stress, it's not related to my lifestyle, and then convince them to go to the therapist, then to convince the therapist that, okay, this is not in my head and I need like very specific help. Like it's also a vicious cycle.
Yeah.
How does are there any tips? Are there any shortcuts?
What is helpful is the patient community. So if you talking to the patients have good experience with certain therapists, share that within your group. And also nowadays, like a lot of clinics have websites, therapists have websites where they also indicate if they have experience with something. So there you can already help your GP being like, okay, refer me to this specific place, please. Or call the therapist before and tell them like, I have this condition. Do you have any experience with it? Or do you know anyone? Because there are quite some psychologists who are also medically trained or who have experience with this condition. So I think if it makes the whole route shorter and more efficient if you already find someone with that knowledge, so you don't have to over explain what you're going through.
And how can we increase awareness within the psychologist field? Is there something we could do as a community so that individuals don't have to fight for awareness that much? Or something like we could do as MyClusters as well?
Yeah. I think why I'm so proud of MyClusters is, first of all, because you managed to take yourself out of a very miserable situation and translate it into action for yourself and the community. Yeah. Well done, you. And what I also stand like from a professional point of view very much behind the idea of MyClusters is because you do combine patient experience with clinical care, with scientific research. And I think that's the way to go, that we have to integrate it to push the agenda forward. And what is helpful is that, and that's something maybe we could discuss, to reach out to educational programs of, for example, the master program or bachelor program for psychology and ask to give a guest lecture about cluster headaches. I know also when I was in Erasmus MC, I was giving lectures in a minor for psychologists and medical doctors on medical psychology. And one whole part of the program was pain, where we tell, the medical doctors in the making more about the psychological variable and the psychologist in the making more about the medical point of view. So I think those initiatives are good to increase awareness and to make sure that professionals have heard about it, which makes it easier to connect the dots and deliver the care that you guys deserve.
Is there also, like if we imagine like a 1-page PDF with all the infographics, with the neat design and everything, is there a global association that we just forward it to and then they send it to everyone, or even national chapters? Could that help?
Yeah, I think so. And like, for example, you were just referring to the study we did with medical students. That's something new that we did actually, which is called the community project, where students of Erasmus MC do research projects. And if you wouldn't have done that, there would have been no project on cluster headaches. So that we did that is actually one first step to broaden the category, like the knowledge on this condition. And those students that we talk to, it's not that, they're well in their third year. It's not that they're already specializing, but they will never forget this condition and they will tell their friends about it. So the knowledge will be broader, more broadly shared. But definitely it's also something we could do.
I'm going to add it to my list. For anyone there that contributed to this study, I just want to give you a quick heads up that we will be soon releasing that report. Thank you again, all of you that contributed to the interviews with the students. And I think that there is a lot more awareness work that needs to be done. But for the psychologists themselves, right? Let's just say if there are psychologists listening that don't know about cluster headaches or how to go about it, what would your advice, suggestion, recommendations be to them?
Well, apart from educate yourself and dive into the literature, because there's quite some literature, I think most importantly, attitude-wise, is take your patient serious. So whatever the patient is telling you, how it feels like, take that serious and work with that. And then design something really specifically for that patient. So we have CBT protocols for anxiety and depression, and you can certainly take inspiration for it. But the condition is so rare and so individually different that you as a psychologist need to create a plan for that individual patient. With some strategies, I believe some strategies of CBT can be helpful. But what you said, like if you're scared of a next attack happening, that thought is valid. I'm not going to take away that thought because it is valid. So we need different strategies to go about it. And that's why it's also important to take inspiration from other therapies.
And the other thing you mentioned as well, right?
Acceptance and commitment therapy. Yeah.
I remember discussing EMDR as well.
Yeah.
Is that, well, I suppose this could be considered trauma. I don't know if that.
Yeah.
But I think in my totally unqualified opinion, every attack can be considered traumatic. I don't know the clinical definition, but I can say from lived experience. And I know from speaking to some in the community that say the onset of cluster headaches was after a severe traumatic incident. So potentially could be some overlap there with the post-traumatic stress
disorder.
Yeah.
Yeah, definitely. And I think two things are important here too. Also, when someone comes in with cluster headaches and seeks treatment for that, to not disregard the other elements of that person. Mm-hmm. As I explained at the beginning with that patient of mine that felt like she doesn't deserve to be happy, I could have only zoomed in on her pain, but I also want to make the focus or the horizon bigger of like, okay, what else happened in your life? What you said, some people report like, yeah, this really horrible thing happened and then I developed cluster headache. I don't know if it's causal. We will never know, but it certainly doesn't hurt to take care of that trauma you experienced before.
Yeah, it's there. Whether it's causal or correlative, it's there.
Yeah, and deal with it as a psychologist. I want to deal with it with you to take that pressure away from you. And certainly it won't work against you. If we clean up that trauma, if we work through it in a therapeutic way, certainly you will benefit from it. That's one thing. And about EMDR specifically, I know that there are specific protocols also for EMDR for patients with pain. And I know we also used it in our department for patients with pain. So that's definitely something to look out for. Be aware for psychologists to do your research, because sometimes the way we use EMDR, because for example, it's about eye movement, that's where the EMDR comes from, rapid eye movement as well, can be triggering for an attack. So do your research, psychologist, and be aware that you don't use the techniques that could potentially trigger an attack.
I think my experience with most treatments is it ends up being a decision of trade-offs. So, if it's verapamil, it's like, yeah, there is a likelihood you might suffer some cardiac issues, but let's weigh that against how many attacks, how painful it is. There is a likelihood of getting medication overuse headache and rebound attacks from triptans, but really, how badly do you need it? And I think I'm not wrong in saying it will be likely the case with EMDR as well. So,
but with EMDR specifically, like usually we do is with fingers or like a light that goes so you'll move your eyes, and you can achieve a similar effect with tapping on your legs, on your shoulders. So if something small like that can already probably reduce the risk of another attack. That's a minimal change we can do as a psychologist.
Are there any like 2 or 3 questions that you would say our listeners can ask when they first have their first consult with a new therapist?
What they can ask the psychologist.
Yeah.
Oops, that's I've never thought about that actually. I think in general, I would just encourage people to be open and again take themselves serious in like sharing the experience they have. Nothing is out of the ordinary, nothing is weird. Just help me understand how it is to be you. And it helps me as a psychologist if you're as honest as possible, even with experiences or thought you might feel shame or guilt. Before we talked about the urge to hurt yourself. If you feel like, I know I shouldn't do it, but I had these thoughts or I actually did it, please feel free to share it because it helps me to understand you better.
It's also hard to share, right? Like, how do you go to a new therapy session and say, yeah, I had these thoughts of hurting myself or killing myself, even if it comes, which is, again, I think it's quite common. I don't think we should not talk about it, but I'm happy to skip this section if you don't want to cover that topic. But how does, what's the approach? Like, how do you deal with it? Have you had any experience with patients that have passive active suicidal thoughts?
I think what is, well, let me still say it and then maybe we have to talk a bit more about it. But maybe what is helpful for patients is me as a psychologist, I've heard it all. I don't get scared easily. I don't get shocked easily. Literally, I've heard everything. So feel free to share it because I'm not going to judge you. I've heard a lot of things before. I'm not going to get scared or angry or shame you or whatever because I know a lot. I've heard a lot. So please feel free to share whatever goes through your mind. And then we can look at it together, even the things that are almost unbearable.
Let's not go into any specific case, but like, what would you tell me if I come to you and say, I'm having so many attacks and I don't want this pain anymore?
Yeah. I think also like what you said, this is a sensitive topic, right? And as healthcare professionals, we always will take these thoughts serious.
Mm-hmm.
I think at the same time, it's also important that we can talk about these thoughts and acknowledge that a lot of times there are thoughts that don't have immediate steps follow. So we don't want to take that lightly and be like, whatever, those are just thoughts. Neither do we immediately want to call the police because again, we want to talk about it and it's important that we talk about it. And a lot of people, unfortunately, have these thoughts. So it is definitely something we want to be aware of as psychologists or medical professionals and talk about it and then see how we can help you when these very negative thoughts come up.
And what exactly are passive suicidal thoughts?
So a lot of people report thoughts of like, if I would have an accident now, I wouldn't mind. Or if I wouldn't wake up tomorrow, I wouldn't mind. So that is different from thoughts of like, I'm going to make an explicit plan of when to end my life and how to do it. Again, both like and the whole range in between are equally important and want to be taken serious.
And at what point does it require, I'm just saying me, if I have these passive thoughts, at what point should I ask for help?
I think if you have these thoughts of like, I don't want to wake up tomorrow, for example, or I wouldn't mind being hit by a bus, reach out for help.
Yeah, it's like, it's not the worst thing if I don't wake up tomorrow because then there's no pain.
Yeah. And that is a very understandable thought, right? Of course, we don't want to encourage anyone. And of course, that's not the way. And luckily, there are other ways to deal with pain. But these thoughts do come up and it's not needed to have these thoughts. So if you ever feel like these thoughts, please reach out to someone because we have techniques and we have different ways to support you in that.
Well, it's pain and then it's I guess what you assume is the burden on others, that you are an inconvenience for your family, your friends, and you just or it's like you don't live the life you used to live before, whether you were, like it's like I was active before, I used to do a lot of sports, now I can't. And then it's that, it's like the disease has taken over and kind of changed my identity. So there's the pain, and of course there's the thought of like it feels so alien to you to even have sometimes like a 24-hour period without pain. And then it's the, yeah, like quality of life. And this is why, like in the other podcast, we spoke to one of our community members from France who even requested for euthanasia. Didn't go through with it in the end, but I think had she not pulled out, it would have been approved. And what she said was, when she went to request for it, there was no conversation about it. It was more like just a checklist, and like, okay, this is what you want. Why? Blah 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 blah. Okay, my liability is done. Yes, you can go ahead with it. So I think it's layered, but yeah, like how do you deal with that?
Yeah.
What do you tell yourself you're in that situation?
Yeah. I think actually it inspires me also to say, like, maybe we can do another recording once with like specific questions from people where I can give more specific advice. But I also want to encourage healthcare professionals. I wouldn't want it to be patients' responsibility to be like, hey, don't you think I should also talk to a psychologist, or to telling their psychologist, don't you think I should also talk to a neurologist? I think it is also our responsibility as healthcare professionals to be mindful enough to be like, hey, you have a lot of pain. I'm, as a psychologist, I can't even prescribe medication. Maybe talk to either a psychiatrist who can give advice on that, or a neurologist, or go back to the GP to find the right path. Same for medical professionals to be like, hey, you don't seem happy. This pain is horrible for you in any way, whatever pain it might be. Maybe also talk to a psychologist just to see how we can support you on the side. Unfortunately, a lot of times it can come across as you imagine the pain, so you talk to a psychologist. It's not like that, because we have a lot of techniques that can help you with the other aspects of life. No one assumes that the pain is not there just because you go to a psychologist.
Anxiety, right? You're not
Yeah.
imagining it. I'm on the SSRIs, and how I know there's a change in the physical way I feel. And I know how I feel if I miss it for a day, or like when the dosage is missed, for example. So potentially, like with the combination of, there is a combination of medication and therapy, right? And then apart from not knowing the drug interactions, I think that's also worth exploring.
Definitely.
And yeah, also before I forget, and we'll add links in the description, of course, but if anyone out there is having these thoughts, having thoughts of harming yourselves, or harming yourself to an extent that you don't want to live anymore, we will leave a link with suicide hotline numbers. But I would also encourage that please talk to someone, community, close family member, friend, your GP, your neurologist, your therapist, if you already have one. I think from the side of community, we just want to say that you are not alone. Many of us have gone through this, and while we may not have solutions, we can always relate to what you're going through. So going back to then the medication plus therapy, is that something that you would also recommend as something worth exploring immediately? Or is it, I mean, it's like, okay, you're imagining the pain, you're imagining the anxiety, like how much of it can be, well, fixed in therapy?
I always find like fixed is as a hard term also, right?
Yeah.
Like,
I mean, I said it all.
but I mean, there is a reason why in guidelines, the first treatment of choice for depression, for example, is psychological help and not necessarily pharmacotherapeutical help. So we can achieve a lot with psychological help. Not saying, again, that we can take away the whole pain. Wouldn't that be great? But we are not able to do that. But I think it's for every healthcare professional and also for patients important to be aware of other methods of dealing with pain and to be open to that, if that's psychological care, medical care. And again, I also don't want to disregard our nurses and our physiotherapists who also have amazing tools for patients. And ideally, if we could combine that, I think we are on the right track.
What's a good first step that we can take or that I can take to put this in the forefront or spread some awareness about this?
I think that what you're doing amazingly is that you are crossing the bridge or building the bridge between patient experience by being a patient yourself, but also by reaching out to the community, bringing the community together, going to all these patient conferences and bringing that experience into the research world, for example. And I know in the Netherlands, also the big funds nowadays, they also demand that we incorporate the knowledge and involve patients in our projects as well, which I find very, very important, because for whom else are we doing it if we don't have the input of patients? So what you're doing very, very well is to connect all the different stakeholders in healthcare with each other, and that hopefully pushes the agenda forward.
Okay, so more work for me.
No work for you, but remember, I also always tell you to take a rest as well.
Yeah.
So I think that's an important one as well.
It's not work when you enjoy it.
It still is.
Anything else? I mean, before, in the interest of time, before we start wrapping up, is there something that you had in mind before coming on that you would like to share with? I mean, our listeners could be anyone, right? They could be in the healthcare system, decision makers, other psychologists, patients, of course, but neurologists. Like, any message?
I think for patients, mostly pain can be whatever pain, particularly cluster headache pain, can be so isolating. And I know it is hard to reach out when you're already down, you don't have energy, and you feel like it's so rare and so isolating. There's no one who could potentially relate to your experience. Please still do reach out. Please, with the last bit of energy, still reach out to people. If these are patient groups, luckily, nowadays with the internet, there are more patient groups out there, more accessible. Reach out to them, reach out to your healthcare professionals, your friends, your family, again, teachers, anyone that you trust, reach out to them and let them help you. I think also pain makes you very independent and autonomous. And sometimes you realize, like, because it's such an individual experience, you feel like no one could ever understand, but still let other people try to help you, because there is more out there. I would encourage everyone to do that. So take your experience seriously and reach out to people so they can help you. And for anyone as a policymaker, healthcare professional, researcher involved in this, is actually the same. Reach out to each other, because I think we make better projects and we become better researchers and healthcare professionals and policymakers if we work together. So let's push that agenda forward to create more multidisciplinary pathways, consortia, and inspire each other to help those patients.
That's a brilliant summary. I think you are not alone as a patient, and as a multidisciplinary community where it's patient groups, researchers, clinicians involved. I think there's so much room for all of us to get together and make much more progress. Thank you, Dr. Jabbarian, for this great conversation. This, I'm sure, will be super useful. Happy to have you on again when we get some more questions. But until then, thank you and have a nice afternoon.
Thank you so much. Bye.